Howdy all. Hope you're all getting the opportunity to join me and see how we get on with this and stuff. It's going to be an interesting live stream because it's just me going solo. And don't worry, I haven't started yet. So if you are jumping in, don't worry about it and things. We will get cracking soon. And I've got an interesting live stream planned for you. As I mentioned, it's just me today. Andy is on a cruise liner, I believe, somewhere. Actually, I don't even know where he's gone. How bad is that? But don't worry, we've got some interesting content coming for you today as we are going to go through some crazy documents in terms of the BMA guidance. And also we're going to try, I emphasis on try, on review the the Darzi review as well, which I have had a brief look at and stuff. But there's some interesting things within there and stuff that I think we definitely need to be looking at and reviewing and things. So I think it's about time we get cracking. So I'm just going to bring up the little graphic and we're going to get started for you all as we look at these interesting documents. Hello EGB learners and welcome to this live stream where I'm going to be reviewing the BMA safe working guidance that came out just recently, and in addition after that tackling the Darzi review, all solo as we try and tech enhance your primary care and learning. Hello EGP learners, there's been loads of things happening in general practice and we've got some really big stuff that's happened in the past few days and likely more stuff to come. But in today's episode, we're going to be talking about two key things. First, we're going to tackle the BMA safe working guidance that came out just a couple of days ago and the website and in particular the documentation that's come with it. And then in addition to that, just yesterday dropped the Darzi review of the NHS and I'm going to try and cover that. Now, the reason why I say try is because I am doing this solo today. Andy is on a cruise ship, having a good time, hopefully, and he will be back in a couple of weeks. So you've just got me for today as we look at these significant documents that I think are going to have a real impact on general practice, probably more than people realize. And we're going to kick off, first of all, looking at the safe working in general practice guidance from the BMA. And if you haven't seen or heard of this, this is obviously part of the collective action that's happening across the entire of the country. And it's the guidance that's come through from the BMA to support practices who are trying to basically deliver their contract. If I'm being brutally honest, it's about trying to deliver your contractual requirements and not doing more than that, which is actually what most of us have probably been doing for many, many years and stuff. So it's going to be interesting to see how this goes. If you want to comment and stuff, do let me know as we go across and let me know what you're thinking. I have even put a poll down below on the YouTube side of things that, are you engaging in safe working? Let me know and stuff in terms of what we're covering. So let's take a look at the BMA safe working guidance. So this is available on their website and I will put the links to these down below at the end of the live stream and things. And effectively, there are key parts of this that you can have a look at. There is the website, which is actually pretty good and where we're going to spend most of the time. I know we tend to spend a lot of the time in the documents, but actually this occasion, the website is pretty good and we're going to spend a lot of time there. There is a full working document that looks like this. That's all 70 pages of it, which is really good detail and goes through a lot of the stuff we're going to cover in a second. Here's the contents, as you can see. So you've got the executive summaries, which me and Andy love looking at. Got the details and then the appendices that goes through all this stuff in a lot more detail. And the appendices actually makes up majority of this document. You can see that the conclusion goes to page 20 only, and you've got the appendices, which is 21 all the way down to 70 something, of which the last 12 pages are the template letters, which we're going to come on to in a second. But there is also the summary document, and if you just want to have a look at this, it's a pretty good read. So I'm going to go through this initially. And the main reason for looking at this is the graphics that you can see. So it starts off obviously talking about safe working guidance and increasing demand. If you want to see the demand and impact it's had, well, here you go. This is a great graph that shows you. So number of GPs in blue, number of patients in orange, and you can clearly see the number of GPs in 2018 to current time has dropped. Slight uptick, yeah, that's quite interesting there. But then the number of patients has been skyrocketing, and actually this then equates to the number of patients per GP has significantly changed from 2006 back in 2018 to 2,295 to full-time equivalent, and that's a significant shift in terms of the number of patients that GPs are having to coordinate and look after and things. Well, let's have a look at the actual demand aspects. This is the index of the number of patients and stuff again. So as you can see, just in the past few years, that the number of patients is increasing, the number of GPs is decreasing. That's not a great sign, is it? And then GPs are responsible for more patients. So on average, each GP is now responsible for an extra 335 patients compared to back in January 2016. So, not even 10 years ago. There's a significant increase there. And that has an impact in terms of the care you can deliver, obviously. It then talks about resources and investment. So satisfaction, first of all. So I think this is from the GP patient surveys. And as you can see, satisfaction back in 2018, really good, 84% good, and then 16% not good or poor. That's a massive shift. And obviously post-COVID, there was a real drop there, wasn't there? Down to 72 and 71%. Creeping back up. I wonder how much of the impact some of the things that many of general practice put in place has had on that. You can clearly see the impact that COVID had subsequently afterwards in the year after COVID and things. But there is record-breaking appointments being made and delivered by general practice. So 31.7 million appointments delivered in July 2024. That is stonking amount. I remember in COVID, we were down to something like 26 million on some months. So that's nearly 5 million more per month that are being delivered. But it does impact on terms of GP. So there's a significant talk about burnout and well-being. And then what are the next stages? Well, the BMA are talking about empowerment and how they can suggest to people about controlling particularly the speed of their hamster wheel. This is a key thing. How can you control what's coming in so you can manage that more effectively? And then we will get to the safe working guidance and stuff. There's lots to talk about appointments. We will cover this. Don't worry. The 15-minute appointments, 25 limit, we will cover in detail. And I would love to know your thoughts on that. So, those of you who are joining us live, please feel free to comment. This is a great graphic, though. So this is the summary of the recommendations that are being made by the BMA. Now, important to remember, the BMA is our union. They will push for harder, kind of, edgier stuff and things. And there's a question about, should they still be pushing for that with the new government, particularly given the new government has said that they will support general practice. That support is still ongoing. So I think, it's worth pushing for it still. But in terms of what they are asking for, particularly from an appointment recommendations to make that pressure felt, 15 minutes appointments in length for all GP appointments. Well, we'll come to that in a second. No more than 3 hours out of the 4 hours and 10 minutes session should be spent consulting. Applies to all GPs, partners, salaries, and locums. And then you should be signposted to other services in the system once capacity is reached. Safety net plans for urgent cases, signposting and duty doctor. Routine appointments may need a wait list if capacity is reached. Communicate system to patients outlining steps should conditions change with clear safety netting, and use the whole practice team and review appointment setup regularly if running over. So this is probably something that I think many people could do anyway and should be doing, but let's take a look in a bit more detail, shall we? It does talk about the daily contacts. So I'm going to spend a little bit of time on this because this is where a lot of the number stuff has come into play. So, the whole concept of 25-minute appointments for general practice and what the BMA is recommending has come from the UAMO, so the European Union of something, general practice. And it's not general practitioners, it's something else. Apologies, I've forgotten what it stands for. But their recommendation for the amount of appointments that primary care should be offering, and actually that's bringing us in line with the European average. Remember that there's some countries much less than I think there's some countries where they do 10 appointments a day. And I remember reading on X recently about American doctors who are putting real criticism about the fact they only get 20 minutes with patients for every contact that they have. You compare to the general practice where 10 minutes, some even less than that. But the reason why they're talking about 25 contacts is that effectively, if you go to 15-minute appointments, 25 contacts works out to 3 hours in a morning clinic and 3 hours in an afternoon clinic, and a little bit overflow because it's meant to be 4 hours and 10 minutes per session. So therefore equating that to effectively a reasonable amount of contact for clinical patients. So 6 hours of clinical contact a day is actually quite a lot of clinical contact. So I think that actually if you equate it in terms of that absolutely makes sense and stuff. the concept of this 25 appointments, I think, varies across practice to practice. And I think there are some practices who feel that, that's too much, too little. It does depend on what your workload looks like. So I think it is important to recognize that the number 25, I think, is the wrong thing to look at. It's the 3 hours that should be looked at more clearly. But I can appreciate that 25 contacts per day is a much better headline than 3 hours. Let's be honest. Okay. But anyway, I just wanted to cover that part because I appreciate people have different perspectives. And, if the BMA are not happy with my comments on that, well, you're welcome to come and join me, to be honest. But hopefully they are, because I think it makes sense. Anyway, we will see. So it talks then about how sessional GPs are integral to components of general practice as well. Absolutely agree with that. And then there's separate guidance for sessional and locum GPs. Now, I will come to this in a second, so don't worry, we'll get to that. And why I have a problem with that as well, because I do, but we'll get there. Engagement and participation, patient participation groups. So it talks about engaging with patients, and I think that's really important. And the BMA have provided data packs and stuff for practices to use to send out about the impact that safe working has on patient experience as well. And working with your local politicians, PPGs, etc., and LMC and stuff and things is really important. It then talks about workload control. We'll come to that in a second. And then later on, some of the stuff that you can do. So particularly around workload transfer, and we'll look at these BMA template letters in a second, but also about measuring your workload. And this is probably something that we're not great at doing. Now, again, I'm going to go on my little soapbox here. So many people know that I'm not a big fan of the GPAD system because it doesn't do what it's meant to be doing. People say it counts for workload, and that's what NHS England used to account for general practice workload. And it does it really poorly, to be honest, because the system providers and the way that it's accounted for do not work effectively. It makes it really hard to do and to change and stuff. And actually, the other part is that NHS England don't look at the administrative component. They have the data, but they don't collect it and they don't use it. So actually, all they care about is the appointments in terms of contacts. So in that sense, it is defunct, to be honest. It's only looking at a very narrow lens at one particular metric that wants to be looked at, and actually marking that particular metric as well is not a great use. So I personally think GPAD is not fit for purpose. I've said that multiple times and things, and I think there should be better markers used. The BMA are recommending that you measure workload yourself, and that you can do that. You can absolutely create templates and stuff to do that. It'd be nice if they created some themselves. I think there is some guidance on how to do it and things, but I just wish there'd been, some decent templates and stuff that would have helped with that. There are clinical systems that can do that as well, though, if you wanted to. They talk about focusing on core general practice and essential services. We will come to that in a second. And workload prioritization. And again, this brings up the inevitable and interesting thing of the GP contract, which I don't think a lot of people really understand. In fact, let's take a look at it now, shall we? So not this. This is the GP contract. So it is an actual, real website you can interact with. Did you know that? Did you know that you can interact with a GP contract? So this is what the contract is in its various forms and stuff. And as you can see, it's a pretty large website going down, down, down. So what are we? Almost over 100 different points that you could have a look at with various different schedules attached onto it that you can absolutely expand into more details and see what is a requirement and things and what isn't. I'll be honest, a better way of engaging with this for me is Anchor AI. It's a platform that I've covered previously on the channel. I will link the video to that at the end of this one, so you can have a look at it if you want to, and that will help to analyze some of this, because Anchor has trained that particular AI based off the GP contract and stuff, although take it with, as ever, a pinch of salt when you're using AI and stuff and things. But sorry, I'm jumping around, aren't I? There we go. I think, understanding the GP contract is a really interesting that many people forget to do and stuff. So who knows? Maybe it's time we all learned about the GP contract in more detail. That's the point. Would you like me and Andy to go through the GP contract? Kind of wishing you say no, to be honest. Have you seen the size of the thing? But anyway, that could be something we could look at. It talks about practice list closures as well, and then details about implementing this guidance and how you can do so, and the checklist, which is about the various different things that you could potentially consider doing. And I do think this is important. So if you're going to read anything from this is the page to have a look at. So the checklist effectively is assessing patients' practice needs in discussion with your team and PPG. Don't forget the patients. Mapping your workload, mapping resource streams and staffing. This is a sensible thing to do. Practice discussion about what you're actually going to consider doing in your practice, and then workload prioritization, focusing on what is the core that you have to do as part of the GP contract and the non-core, and where necessary, using workload controlled templates to manage that. This could be cutting back or stopping on various local enhanced services, or more importantly, not doing work you're not contracted to do. You should absolutely engage stakeholders, so your PPG councillors, health washing commissioners. Communication, and you can use various different methods, like letters. It says Accurix, I think it should say SMS, but okay, Accurix is a predominant user. Establish triage processes and use the whole practice team, because triage does work when you do it effectively. Signpost alternate services, because you can do that when you started triaging, and safety net processes, and build those into your practice teams. Use templates and things I would highly recommend. And then appointment setups. So 25 limit at 15 minutes. That's the big headline that many people are focusing on. And I've already talked about what I think is appropriate and not in that sense, from my personal view. Monitoring and review experience numbers, qual and quantitative information, I'm assuming, and reviewing job plans and clinics as appropriate. And this may be a discussion that people have, in particular with things with the uplifts and stuff. And there you go. So it talks about the appointments being 15 minutes in length. This is something that you can do in practice. This is something that practices can do if you feel appropriate to do so. Now, the reason why I say if, I think there are different situations where 15 minutes is appropriate. Absolutely. I think there's times where actually more is appropriate. I think there's also times when less is appropriate as well, depending on what you're doing. You don't need 15 minutes to do a flu vax, for example. And to be honest, GPs shouldn't really be doing flu vaccinations. It can be a nice thing to do, but it's not the best thing, use of your time. I think this is more important than no more than 3 hours of clinical contact, and focusing on that as your metric when you're creating these clinics and stuff. This should apply to all GPs, partner, salaried, and locum. We will come to this bit in a second. And clinical staff undertaking consultations. This should also apply to your AHPs in practice, so your nurses, pharmacists, PAs, physiotherapists, etc. Consider how they work in this. It's not just about GPs. This is about primary care. Signpost to other services in the system once capacity is reached. Safety net plans for urgent cases. Routine appointments may have a waiting list. So they do talk about how to create a waiting list for your patients if need be, and communicate to patients and outlining the steps should conditions change with clear safety netting. Really important, given particularly things like hospital wait times, ambulance wait times, etc. and stuff. Use the whole practice team and review the appointment setup regularly as well. And then it talks a little bit more about waiting lists, that you should provide reasonable needs for your patients, have safety netting, be addressed in communication, education, training, blah, 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 and all this stuff. It's really sensible things. And then you've got the conclusion, which basically summarizes all of that for you. But hopefully we've covered all that in detail. Now, what I am going to talk you through now, and I think this is the part that's really useful for people to have a look at, is the website. So this does go through in more detail. It's got the links to the original documents on the homepage, but if you click on the left-hand side, you go to the different topics. So measuring workload, okay? So they have provided some primary care guides, so particularly from West Lothian, to help you support doing this. And they recommend, due to the challenge of recording counting all patient contact via appointments book, because even the BMA agree that GPAD is not great, and we would recommend practice undertake a period of manual recording over 2 to 3 day period. By doing so, it's possible for practice to better measure and account for all patient contact. It includes brief, informal types, and as well as discussions with community teams regarding specific patients, calling back patients, etc. and things. And that is potentially more useful data to understand, because that's true demand that comes through. Next, they talk about external unresourced workload. So practices normally do not have capacity to take on workload, but from other places, and it talks about the template letters that are available to help you navigate some of these things. And a lot of this is the workload pressures that we see from other parts of the system. So let's have a look at these, shall we? So I'm going to go all the way down to the bottom of the annex, and we can see some of these letters here. So let's so the useful thing is that these are available to download. So let me show you where exactly. So if you wanted to download, you click on this and that takes you to the templates, which is this page here. And then you can download either the templates in a Word form, or if you go down to the bottom, you can download the packs that give you and how to upload them for System 1, EMIS, and Vision. So 3 main clinical systems currently used in England and stuff. Okay. But these are what they look like. So, dear, so this is a template response for secondary care work transfer. Dear Dr. X, I refer you to this patient. I'm sorry unable to undertake this for this reason, and that being one of these 4 things. So task is not essential service, it's not work commissioned by RCB, it's not been funded a national local enhanced service, and work is more appropriately provided by yourself as specialist, and therefore justification and where you can send that information through and stuff. And it links out to essential services here on some of the other documents. It links out to GMC duty of care. There's other parts where there are these web links and stuff. And I think the letters are okay. I know there's been some commentary from some people about that they're not strong enough, that they don't have enough detail. You have to have a general letter that kind of works for majority. So I do understand that. I think one thing I would have done differently, and hopefully BMA listening to this, I would have actually put either the web links on the bottom of the page, so you can actually see them, because the problem is if you're sending these as a physical letter, which some people may be, obviously the hyperlink is completely useless in that situation. Or better yet, put the QR codes to the hyperlinks on the letter as well. That would have been really smart. I think that should have happened. Do you? Let me know in the chat. So speaking of the chat, let's just take a quick look. So we have had some comments. Apologies, I've normally got Andy here, so I don't have to go on at everything and stuff. So Will Smith, I wonder if that's the real Will Smith. How important are staff such as ours to achieving these appointment targets? I think they're a key part of it, to be honest. They are additional workforce provided to help general practice navigate and support their patients. Absolutely, ours should be supporting this. I think their clinics should also reflect, safe working, because that's sensible. Does that mean that they should be doing 15-minute appointments? Maybe. It depends on their clinical role and stuff. A mental health worker, for example, I don't think really should be doing regular appointments of 15 minutes because, is that a sensible way for them to operate? They probably would need more time for some of those more complex, challenging patients and stuff. But, an experienced clinician should be able to assess and review a patient ideally within 15 minutes for the majority of things and for majority of the roles and stuff. Prash, you put a comment in that that'll take you several hours. I'm assuming that's you talking about the GMS contract. You are correct. It would probably take several hours to review, but I don't know. Maybe me and Andy can give it a go one day. How about this? If 100 people comment on this video asking us to review the GMS contract, me and Andy will do it. How's that? Okay? 100 comments saying that we should do it. And please not from a bot, okay? Will Smith, is the R scheme being expanded? So we've covered this already in one of our earlier videos about how it is not currently being expanded apart from the GP&R scheme. So that video is on the channel. We did that about a month and a bit ago, and we don't have the full details of that yet and stuff, but hopefully we'll find that next few weeks. And then doing the maths, 3 hours of clinical contacts equates to 12 patients, so 2 sessions a day, 24 patients, not 25. I know it's not 25. I did say that there's a little bit left over, so it's the 4 hours and 10 minutes, and therefore there's some flux in there based on you doing a full day. I think that's why they put it at 25 to account for the fact that not every clinical contact is a 15-minute consultation, is my understanding. But the UAMO is actually, the 25 is actually the UAMO criteria of 25 contacts a day. The BMA have equated to the closest possible thing, which is 15 minutes, 3 hours contact, hence 12 times 2, which is 24. So hopefully that helps Prash and things, because they are slightly different things, and that's why I think people sometimes get confused with how they would be implemented, and that's why my perception is 3 hours worth of clinical contact per clinic is a sensible thing to do. Anyway, let's go back to that's all the comments we've got. So let's go back to the actual document about unresourced workload. So we talked about how this can be really impactful in terms of sending this back to the variety of places. And this is the thing I would also say, be kind in your comments and stuff, because otherwise it can cause more friction. And remembering that secondary care is also under significant strain. I don't believe that's also the reason why they should ask us to do a lot of their work. And I think a lot of it is more about education rather than intent, to be honest, but that may be different in your area. Next, it talks about appointments. So this is the part that I talked about at length about the 25 contacts, 15-minute appointments. It does recognize that many practices still provide care at 10-minute intervals, and that's meant to be for record keeping and housekeeping between patients. This is not something that you need permission to do as such. This is a practice decision to make, ideally led by the partners, and hopefully would engage both the partners and the salaries. And I think it should be the same for every clinician working in the practice, ideally aiming towards that 15 minutes of contact time. I think, they should allow people to spend time appropriately, to be honest. That's what we should all be aiming for and stuff. And, it will help from there. But I think remembering that not every contact is necessarily the same amount of work. That's the key thing. So, if you've got assistive support from, for example, total triage models where you've got some of that information already, does that contact, is it more sensible it can be dealt with in less time? And then actually, can you then use blocks of time to catch up? So, for example, if you're bringing a patient down for the same one, actually have 2 blocks of 7.5 minutes to make up the 15 minutes where that's appropriate, and some catch-up time, and then some other time built into, let's see, other types. Okay, I think there's different options and solutions, and that's what we do in my practice. So we've got a hybrid system that basically allows people to hopefully control their workload a lot more effectively and things. Daily working contacts. So this is where we talked about, so European Union of General Practitioners recommended a safe level of 25 contacts per day. So that's the safe level, okay? That's what they recommend. And again, that differs between what is a contact. It does talk about how you can have appropriate care coordination, how that can help. And then there's some stuff about the directory of services. So this is the CCAS appointments that one can book into and things. And then also how salaried GPs are, sessional GPs are integral to basically this functioning. And where are we? Explaining to PPG. So basically, understanding the concept of contacts. There's the waiting list page. So this goes into a little bit more detail about, what the contract means and how that functions, and also how you can have a waiting list for patients with chronic conditions potentially, or, non-urgent health issues, and brought in on days when you have different levels of capacity. Talks about patient participation groups and how engaging with patients and explaining things to them is really important and sensible and stuff. And actually, I agree with this. So when my practice changed to a total triage system, I spent a lot of time engaging with the patients, and I even did a live stream open meeting for them for patients where we had 40 patients turn up, and over 1,000 patients watch online now for that particular video explaining the appointment system changes at our practice and stuff. And there's some guidance on what you can do. There's some templates, as I mentioned, that you can use as letters to send out to people, as well as there's some data packs and stuff that you can use. It does talk about using OPAL or SITREP mechanisms if you've got them in your area, about what general practice is under the strain and stuff, and therefore how that will impact and things and stuff. And then for salaried GPs, about job planning as well, in terms of understanding that for everybody else. Core general practice, it then talks about this, and I think this is one I'm going to show you. So one of the things it talks about is obviously how practices should be aiming to offer core general practice. But then there are other services that can be delivered, and it may be sensible for you to deliver. And that's this particular page that talks about them. So you've got the direct enhanced services, which are the nationally agreed enhanced services. There is a NES, a national enhanced service, a slightly different terminology, and that was the COVID vaccination was done under a NES rather than a DES, and that's because the rules around changing them are slightly different. But actually, more commonly, what most people are probably aware of are the local enhanced services, and this is a list that people have come across already that the BMA is sharing that does constitute as a LES in many places. So, let's look at these, shall we? So 24-hour BP monitoring is a LES. Ambulatory ECGs is a LES. Non-urgent ECGs is a LES. Post-discharge input is a LES. Extended hours is a LES. Lumps and bumps and minor surgeries is a LES. These are all things that you don't have to do and should be contracted to do as an extra and paid for appropriately. So dermoscopies on there, neonatal checks are considered LESs. Alcohol and substance misuse. Flu immunization is a local enhanced service to a degree, and that I must admit I wasn't aware of that one. I thought it was part of our contract. Smoking cessation, the delivery of it is, a local enhanced service, and it's often held by public health, can be contracted to practice if they want to. Various others, homeless services, various monitoring, specialist drug monitoring. Oh my gosh, shared care is a local enhanced service. You should not be doing it unless you are reimbursed for doing so, because it is extra work out of your contract. Let's get to the more interesting one, shall we? Phlebotomy. Did you know phlebotomy is not part of the core contract? It's not. these are things people don't know about. So important to recognize that these are a list of the various different local enhanced services that you should ideally be either commissioned and paid for doing rather than just doing it gratis, because actually that impacts your core abilities of work to do, and therefore should you therefore be doing it. The BMA do support the fact that practices can choose to close a list if they feel they do not have the capacity to provide safe care to their patients. Emphasis here on safe care to their patients, but there are protocols and there are processes you need to follow. And then it's normally the case that up to 12 months is the maximum you can be allowed to close unless there are significantly exceptional circumstances and stuff. Let's talk about workload prioritization. So non-contractual work should only be diverted to other areas, is the BMA's guidance and stuff. And again, they talk about the GMS contract. Basically, care outside of the core GMS contract is detailed in the DES, the LCS, the Local Enhanced Services, QOF, and IF arrangements, which we've talked about at various times on the channel as well. Let's talk about some DESs. So the primary care DES. So this is one that me and Andy talk about on a regular basis. I've got slight conflict here. Obviously, I am a primary care clinical director. And this was the big contract that was negotiated just over 5 years ago and continues to have impact on how general practice functions. Key parts of this was the £1.76 participation payment per registered patient, and then the £1.50 for the core services, as well as obviously additional funding for IAF, and then the big chunk, which was the Rs reimbursement. And then there were some extra payments for things like, well, to pay for me, but also other resources and like leadership and development and other things that happened, and particularly the COVID vaccinations when COVID kicked off. It is important to remember that NHSE published its proposals for 24-25 without the agreement with the GPC, so it's not agreed, it's not contractually mandated in that sense. But obviously, if you are planning on setting out, then important, not continuing with the DES, then there are impacts that you would receive. So you wouldn't get the participation payments, you wouldn't be able to do any of the work or receive any of the funding for those contractual aspects, and then that would include the R staff as well. So bearing that in mind. So the next two sections are the part where it talks about managing workload as a salary GP and then managing workload as a locum. So let's talk about these, because I have a slight problem with these, and you're going to find out why in a second. So salary GPs on a time-based contract remunerated with the care they are expected to do and include direct line care, etc., and working to European Working Time Directive. Fine. Indirect clinical care does not necessarily mean time spent in team meetings. Salary GPs currently work on average 25% additional hours on top of their core contracted hours, according to surveys, and they should be recognised with time in lieu or doctor's diary application may help in identifying these additional hours. I've not come across that application, but hey, give it a try. It talks about various different things about prioritization, how identify areas which can be dropped from the salary order to enable them to continue working within their contract. So, it's probably worth doing this as an exercise in your practice. I often talk about trying to identify the key problems that you've got, and this can be a good positive way of doing so. And then devise a job plan to make it more sensible and stuff, and working for this 3-to-1 ratio of clinical to indirect clinical care, and then time out for meetings and stuff. Increased demands of general practice must not cause salaried GPs to work beyond their contracted hours, and effective planning can take that into account. Fine. That sounds sensible and reasonable. I think there are absolutely challenges in achieving that in many places because, well, we've kind of become indoctrinated that we just work harder, haven't we? But it's doable, I think. Managing workloads locums work as self-employed. So talking about, how they can be reflected in terms of offering different terms based on different services. I think, every locum is different, and therefore understanding that. Advice and guidance referral system. I don't know why this isn't the locum bit, but increasingly about the use of A&G and how trusts are using that, and then it can't be mandated and stuff. And absolutely agree. I mean, this should have been a separate section in my view. I don't quite understand why it's in the locum section. So that's one thing I did have a bit of an issue with. But I said earlier that I had a problem with these two. And the reason why I have a problem with these two is because what isn't here is managing workload as a GP partner. Now, I suspect that there's an assumption that all this other stuff is basically taken into account GP partners. But actually, that's the part that's the hardest one to do. And I do find it a little bit annoying. And I know I'm being critical of the BMA here slightly. But I don't understand why there isn't a section to help GP partners actually understand how they can reduce their workload. And and again, happy for the BMA to tell me otherwise. I probably guess that it's because they think that all the other stuff is the contractual responsibility and that's the partner's responsibility. But actually, just another section saying GP partners, that would have really been nice in my view. I don't know. What do you think? Do you agree? Do you disagree? Let me know. And then we've got the scenarios of safe working. Various different capacity issues and stuff and where you can look at it, managing patient expectations and how you can provide clear information to tackle that, and handling high demand periods. So about having flexible staff, using technology, understanding how that can work, and looking after self well-being and preventing burnout and things. There's some really good stuff here, actually. I think it's really powerful things, and I would highly recommend having a look at that. And then there's some case studies as well. So realistic rotas is limited to 13 per session. And then, duty doctor calculate how many on-the-day appointments available that day, and duty list is capped to that number. And then how many consultations do they offer, looking at various different capacities with 111 and various other things and stuff, and, how it can work. I know in my practice, I think the salaried regular clinics that we have for GPs, nurses, and various other things are working quite well. It's the on-call I think we still need to work on in my practice to make it more sensible and realistic. And then, do you need to use a coded system for your appointments and things? Maybe. Do you have RAG rating for your appointments? Teams, depending on your size and stuff. And it does talk about how, you can improve capacity, you can actually improve continuity, and that leads to generally better care, we know, for patients and stuff, and then how that can work in terms of the day that you have and things. So I think there's lots of really useful stuff in there and things that you might want to have a look at. It then finishes off by signposting you to the Safe Working webinar. So it's a webinar recorded by the GPC that you can have a look at. And that's obviously there. There's also some FAQs. There's some interesting ones here. Where's the one I wanted to look at? How do you implement a set waiting list? How do you improve your triage systems? What was the question I wanted to... here we are. How do we define a patient contact? So we're advising that it is 25 consultations per day, interactions that would require speaking or engaging with the patient, for example, face-to-face or telephone, etc. Administrative, medication, and urgent queries need to be built into clinics so that the time spent on direct and indirect patient care is properly accounted for. Significant tasks like reviewing complex investigations, medical record reviews require proper acknowledgement time. The duty on-call rota should have time to focus on true emergencies and queries to help support safe working. So a bit more context there in terms of what is a patient contact and things from there. So that is the safe working guidance by the BMA. So it's taken us about 40 minutes to go through that in detail. And hopefully you've all found that useful and effective. I would love to know your thoughts on what that looks like and stuff for you. And I've got some more comments coming in, so feel free to stick those in for those of you who are watching us live. I'm happy to answer them and stuff. So Prash again has come in with agreed totally for partners. I'm assuming that's about the fact that there's little limit comments in there about partners and stuff. I think one really interesting thought I had recently from somebody else was that the BMA is predominantly actually hospital doctors rather than GPs, which is probably why there's potentially sometimes less stuff badged under the BMA for general practice. But also out of that is predominantly salaried GPs that are members of the BMA, more so than partners because of the employment support and things that happen. But also partners tend to be less engaged with the BMA for some weird reason. I don't know why. Obviously, I'm a partner and I'm engaged with the BMA. But I think it is interesting that a lot of the stuff that comes out is very much focused on salaried doctors and sessional GPs. And I think that's right in some way because they have different requirements and needs. But all I would say to the BMA is a little bit more detail for partners out there, because ultimately they're the ones having to make these decisions. And I know, for example, the recent surveys were partner focused because they had to be contractually, because it's the partners again that hold the contracts and stuff. But you can't over communicate on these things sometimes. It's one of those things that's just nice to be really clear about the support and offerings that are there and stuff. But let's talk about something else now, shall we? So another thing that came out yesterday that is possibly even more significant for now, because it's having an impact on what's happening, is the Darzi report. So this If you have not heard about this, you kind of need to know about it, because it's going to be interesting how the impact of this report has. But the Darzi review, effectively, is by Darzi. And for those of you who've been in general practice for a while, you may remember he's the person that about, what was it, 15 years ago, possibly a little bit more, came up with things like the Darzi centres, Darzi clinics and things. So these were the urgent care access clinics. And at that time, a lot of people kind of felt the review was not great, shall we say, because how much did it spend using stuff and things. He's been asked to do another review, and we're going to take a little look at that right now, shall we? So this is the independent investigation of the National Health Service in England. So published September 2024, in fact, yesterday. So I'll date it for you if you want. It's a pretty significant review. If you can see the number, it's 163 pages. And the first part in the introduction apparently starts on page 16 after the summary and stuff, which is what we're going to focus on. Then talks about the health of the nation, access to NHS, quality of care in the NHS, health protection promotion, where the money is and how it's spent. That's going to be a great section to go through, isn't it? Health and prosperity, and then drivers of performance, funding, investment, tech, impact of COVID, patient voice, NHS structures and systems, NHS in critical condition, and basically what's going to happen there. So I will be honest, I cannot cover this entire document by myself. This is where I would absolutely need Andy. So what I'm going to do is go through the summary, the executive summary, and then I'm also going to go through the conclusions and stuff. And we're going to jump around a little bit for some key points in there. So let's take a look at the executive summary, because that's where a lot of the stuff is. I'd really like this summary, because it's very well set out. It is very clear. And actually, if you wanted to, you could just read the headline statements. It's that good. So it starts off by, so this is a report to the Secretary of State of Health, so to Wes Streeting. He's been asked to basically do this review. And the first line is what I think many of us understand and know, that the National Health Service is in serious trouble. So British people rely on it, and that it has generally had high public satisfaction, and now it's at its lowest ever. He does mention that the first step is to rebuild public trust and confidence in the NHS, and to be completely honest about where it stands. And I must admit, I like that honesty. Let's be clear about where it sits currently and things. The state of the NHS is not due entirely to what has happened within the health service. The health of the nation has deteriorated, and that impacts its performance. So recognizing that wider things, particularly COVID, have had an impact in terms of it, but also other stuff like social determinants of health. So myself and Andy have talked about these on a regular basis, that these have an impact in terms of how people cope, and that there's been a surge in multiple long-term conditions, particularly among children and young people, and in mental health aspects as well, that's having an ongoing impact in terms of what people are experiencing from health. This report then sets out where the NHS now stands, and we've arrived at this point, and some of the key remedies that Darzi feels that can be offered. Okay, let's have a little look. So the performance of the NHS, how long people wait, and the quality of treatment that are at the heart of the social contract between NHS and the people. NHS has not been able to meet its most important promises made to these people since 2015. Wow. So a few years after austerity kicked in, obviously it started to fail, and this was pre-COVID, according to Darzi. And that talks about various services and stuff that occurred. People are struggling to see their GP. I think no one would doubt that that's a challenge. I think some places do it better than others, and I think some places do it worse than others. But the key thing is GPs are seeing more patients before, and the fully qualified GPs relative to the population is falling, waiting times, etc. up. And there is a huge unwarranted variation in the number of patients per GP, and shortages are particularly acute in deprived communities. Yes. Thank you for somebody for officially saying it. I mean, I know it's been said in other fora, but, it's nice to see that this is being recognised as a problem, that health inequalities is a real challenge. Waiting lists for community services and mental health has surged. So the fact that there's so many people waiting for services and stuff, and that the long waits have become normalised. This is an interesting aspect, that actually, because of the long waits, it changed the way you have to clinically manage patients and stuff. That is depressing. I mean, can you get more impactful than a sentence like that? A&E is in an awful state. Everyone knows that. The three types of A&E department. Type 1 is the way most people think of an A&E. They're major desk departments. And type 2 is specific conditions such as dental ophthalmology. Type 3 are for minor illnesses and stuff. the fact that, there's so much impact on these is really significant and things. And, Royal College of Emergency Medicine, long waits likely to be causing an additional 14,000 more deaths a year. Waiting times for hospital procedures have ballooned. I mean, I'd say mushroomed, I'd say exploded. I think, it's crazy how long people are having to wait for operations and various other things. And that has an impact on the rest of the healthcare, the service, as well as general practice as well, because people keep coming back because they haven't had their treatments, and therefore this has an impact from there. Cancer care still lags behind other countries. If you go back to the points where UK was ranked one of the highest providers of the G8 and various other Commonwealth and all the other things, the one thing that we were always less good at was cancer care, and this still continues to be the case, unfortunately. And therefore, time to treatment has had a real impact and stuff and things from there. Care for cardiovascular conditions is going in the wrong direction. So, one suggested for age, cardiovascular mortality is changing, and actually, the access to treatment has changed. It's got worse, and therefore, that's having an impact, obviously, in terms of people's health. And the picture of quality of care is mixed. So, I think that's understandable and stuff. So, how certain things can help and other things can't. The NHS budget is not being spent where it should be. Too great a share is spent in hospitals, too little in the community, and productivity is too low. So this is an interesting part, because obviously the hospitals use bulk load of the financial spend that is within the NHS, because they also do more expensive treatments, they deliver more expensive care. But actually, there's this recognition that in order to have more cost-effective care, you need to move this care to the community. But in order to do that, the money needs to flow. So actually, this is where a challenge is. It talks about the fact that, the staff working in there, the number of appointments, operations, etc., has not increased at the same rate that the number of staff has increased by. I think I saw one comment that, in 20 years, the population has gone up by 10 million, but the number of people working within the NHS has gone from 1 million to 1.8 million in that same time. That doesn't seem, in the same ratio. And actually, majority of that has been hospital-based care compared to primary care or community care. It does talk about the lack of capital investment, and that's prevented a lot of the hospitals being built. So previous governments commented about 40 new hospitals, and we know that that's not the case. And productivity doesn't reduce workload. In the way as well. Yeah. Okay. So it needs to be stressed that failing productivity doesn't reduce the workload for the staff. Okay. And that's true. Too many people end up in hospital because too little time spent in the community, and because we've underinvested in the community is a key aspect to this. And therefore we have almost 16% fewer fully qualified GPs other than high income countries. So OECD 19, and relative to our population. So the cuts have had an impact in that. And we are still seeing that shift away from things. The NHS is not contributing to national prosperity as it could do. So that's a key comment that he's made. I'm not going to go into that more detail now. So drivers of performance, 4 heavily interrelated factors have contributed to the current dire state. So number 1, austerity. 2010 was the most austere decade since the NHS was founded, with spending growth around 1% in real terms. I don't think anyone could disagree with that. There was an increase, a more realistic promise was made of 3.4% in 2018 for the 70th birthday. But that did not include capital spending, medical training, or other increase in public health expenditure. The 2008 funding promise was broken, and it was just under 3% of result. Capital, NHS has been starved of capital. So this is the total budget of it, because it's being used to plug day-to-day spending. We're seeing this with many ICBs, that they are using those funds to basically back end the books, so that then they're not in as much of a dire situation and stuff. And then on top of that, there's a 37 billion of capital investment shortfall. So if there had been the investment that kept pace, that's how much more funding would be available for healthcare in order to deliver various different things, and that impacts the buildings that we can work from, the resources that people have. They comment about crumbling buildings, mental health patients being accommodated in Victoria era cells infested with vermin, with 17 men sharing 2 showers. Oh gosh, that is bad, isn't it? And then, sorry, I just can't correlate on that one. And the pandemic, the impact of the pandemic and its after impact, particularly the bigger backlog than any other health system. And this is the key part. Whilst many will absolutely attribute the COVID pandemic to being an impact on the strained system, the strain that NHS was already under was even more significant, and the backlog that's been as a result of it is taking even longer to recover for within the NHS and stuff. And it says it here, what is less widely known is that the NHS delayed, cancelled or postponed far more routine care during the pandemic than any comparable health system. Even I didn't know that. So there you go. There's a new factoid in there that's probably sensible and important to hear. Talks about the fact that patient engagement, the patient voice is not loud enough. And I think that would be, I'd agree with that, to be honest. I think the right patient voice is not loud enough. I think patients need to tell practices, they need to tell their health system what they want. I think individual patient voices can be loud. I think some are quiet as well. But I think that unified voice needs to be clearer to people about what needs to happen. And staff engagement is, because too many staff are disengaged, and so many staff are struggling right now. I think that's really true, and that actually, we should have a better way of engaging with our staff to make sure that they understand what everything is happening and how it can be more effective. Management structures and systems still reeling for turbulent decade of growth and the growth in oversight. It feels like everything is oversight and no one's doing the doing, to be honest. And a further effect of 2012 has been a costly and distracting process for the constant reorganisation of the headquarters and regulatory functions of the NHS. So this was down to the changes made by the Tory government, particularly the Lansley reforms that many people will remember, the Health and Care Act of 2012, and this brought in various aspects such as regulation, competition, and how that's been less effective. There is one point, I think Darzi talks about CQC and its effectiveness and stuff, but we'll come to that maybe later on. But let's talk about the conclusions. The NHS is in critical condition because vital signs are strong. It's apparent that from this report, there are company analysis the NHS is in a critical condition. Some have suggested this is primarily a favour of NHS management. They are wrong. So a lot of the papers that say it's all down to too many managers and stuff and things, according to Darzi, that's not correct. Some fantasize about an imaginary where the heroic NHS managers were able to defy the odds and deliver great performance in a system that had been broken. Better management decisions may have been taken along the way, but I'm convinced that would only made a marginal difference to the state that the NHS is in today. Yeah, interesting there. Despite the NHS, the challenges, the vital signs remain strong. So he does feel there's still a huge amount of depth and talent and stuff that exists. Nothing that I have found draws into question the principles of a health service that is taxpayer funded, free at the point of use, and based on need, not ability to pay. So focusing on the aspect that there should be free access. And it talks about, with the prominent exception of the United States, every advanced country has universal health coverage and the rest of the world are striving towards it. But health models whose user charge, social, private, and should play a bigger role, are more expensive, even if their funding tends to be more stable. It's not a question, therefore, whether we can afford the NHS. Rather, we cannot afford not to have the NHS. So it's imperative we turn the situation around. He talks about it's taken more than a decade for the NHS to fall into repair, and that improving it will take time. And some important themes emerged on how the NHS will be able to consider strategies to improve the nation's health and stuff. So basically, he talks about the key aspects we need to do. We need to re-engage the staff. We need to lock in a shift of closer to care to home by hardwiring financial flows. General practice, mental health, and community services will need to expand and adapt to the needs of long-term conditions whose prevalence is growing rapidly in a population age. Financial flows must lock in this change irreversibly, or it will not happen. Money needs to flow to community services to help out. Simplify and innovate care for a neighbourhood NHS. Neighbourhood, an interesting word, because we are talking about INTs, integrated neighbourhood teams and stuff currently. Drive productivity in hospitals. So acute providers will need to bring down waiting lists by radically improving their productivity. This means fixing flow, for example. Tilt towards technology. A little alliteration there. There must be a major tilt towards technology to unlock productivity. In particular, thousands of NHS working at hospital urgently benefits of digital systems. There's enormous potential for AI transformed care. Yes, safely. We need to look at that a bit more detail, I think. And to contribute to national prosperity. With the NHS budget 165 million this year, service productivity is vital for nation to prosper. Prosperity. Oh, so too many P's in there, isn't there? And reform will take to make the structure deliver. While top-down reorganisation of the NHS in England and integrated is neither necessary nor desirable. So this will be interesting because actually Keir Starmer was talking about reform. And actually, Darzi says that it's not desirable. There is more work to be done to clarify the roles and accountabilities and ensure the right balance of the management resource in different parts of the structure. So change will only be successful when NHS can have the capacity to deliver the strategies we make. So what does that mean? Well, there's lots to look at here, okay? I'm going to try and find one particular... Sure. Where are we? I know, I should have had this ready, shouldn't I? Here we are. So this is page 780, okay? And I really want to highlight this word. As independent businesses, general practice has the best financial discipline in the health service family, as they cannot run large deficits in the belief that they will be bailed out. I think that's the real key thing to look at and stuff, that actually general practice has had such an impact in terms of how it works. It's the only part that doesn't go into the red and stuff. And in this section, so general practice section, he talks about being the jewel of the crown, how low it is in compared to where everyone else is in the healthcare service because of the lack of funding and resources and because of the impact it's had. And definite variations that exist. You compare, so here's the number of GPs and doctors. There's some excellent tables in here that talk about the number of staff compared to other roles in hospital and stuff. You can see significant difference and stuff and things that's happening. And the workload is unparalleled and stuff and things. With primary care doing more work for a lesser share of the NHS budget, we heard significant irritation by GPs. Yep, I'm probably one of them, to be honest, and stuff. And the challenge that practices are facing that comes with that as well. And the primary care, this is a key one, primary care estate is plainly not fit for purpose. Indeed, 20% of the GP estates predates the founding of the NHS itself, and 53% is more than 30 years old. More recent buildings are bedeviled by problems with the management of lift, PFI schemes, and give GPs little control of their space and described as having charges that are unreasonably high. I would definitely agree with that. During visits to frontline investigation, just urgent reform. So basically, there is absolutely some changes needs to happen and things. So let's just have a look at the conclusion, then I'll come to some of the comments that we've got. Conclusion. The NHS in critical bits vital signs are strong. Apparent from the report that there's stuff to do. Suggests it's the failure that NHS managers. The NHS is essentially a public service, so managers are focused on keeping the show on the road. And that actually, Darzi does not feel this is a result of the managers, although there are lessons that can be learned. He feels the NHS is strong, and it doesn't draw into question about the principles of the NHS, and that for more than a decade it's taken a while for this to happen. It's going to take a while for it to be fixed. And then he set out these 6, 7, 8 principles. Okay, so just to remind you, so re-engage the staff and re-empower patients, lock and shift of care close to home by hardwiring financial flows, simplify and innovate care delivery for the neighbourhood of the NHS, drive productivity in hospitals, tilt towards technology, contribute to nation's prosperity, and reform to make the structure to deliver. Those are the key aspects that Darzi is effectively recommending. And then he feels that a lot of that exists within NHS, but we need to work harder towards it and stuff. So that's Darzi's comments on the NHS. Now, what will be interesting to see is the government's response to these, and already we're hearing about another reform coming from Starmer and various other aspects. So it'll be interesting to see how this percolates down, and absolutely myself and Andy will be here to cover that for you as it happens. I guess some questions we've had. So does Darzi mention the neighbourhood NHS? Report mentioned the NHS is primary care on track to deliver a neighbourhood NHS. I don't know. I think that's possibly a delivery mechanism through ICBs, as we see smaller areas potentially contracting care, if that was to be the direction of trend. But also there's this question about actually, is the current regulatory process satisfactory enough to deliver some of this kind of things? And important to remember, almost every ICB across the country is facing a deficit this financial year. So that's going to be interesting. Where's the money coming from? So it'll be interesting to see what plans are made and what we can expect to see moving forward. And I think it'll be really keen to see what happens. I think if you want to have a look at that, feel free to absolutely look at those documents. I'll put them down below. I think additionally, myself and Andy will be here over the next few weeks to try and cover this when Andy's back from his holiday. Next week, we're going to talk about something different. We're going to talk about conferences because it's conference season, including the party political conference seasons that we're going to see coming up, as well as some other conferences you may want to attend. And if you want to see me and Andy live, that's the best way to do so. And if you want to check out that video I mentioned, which was the one about Anki AI, check out right here. And we'll be here to take and answer your primary care and learning. And catch you in the next episode.